Welcome to the weekly neurology deep dive. Just a reminder, this deep dive is strictly for educational purposes. We have no commercial goals here.
That's right. It's a summary based on material provided by a listener, and we really do recommend you read the full papers yourself for the complete picture.
Today we're diving into a pretty recent review article. It's titled A Practical Guide to Assessing Functional Motor Weakness, a review of validated techniques.
Ah, yes, by James Dolbo and colleagues Elazuni, Zhang, and Geiger, published in the Journal of Neurology, 2025.
Exactly. And functional neurological symptom disorder, specifically functional limb weakness, it's something we all see quite commonly in practice, right?
Absolutely. But, telling it apart from objective neurological weakness, the kind with a clear structural or electrophysiological cause, well, that can be genuinely challenging sometimes.
It really can. So this review looks at the literature, and it analyzes 9 specific examination techniques that have actually undergone some validity testing.
Their aim was pretty clear: lay out the exact technique used in those validation studies, plus the number sensitivity, specificity, and also the clinical applications, and importantly, the limitations.
Basically, a practical guide for us to use day to day. So let's unpack what this review offers for your clinical practice.
Well, first off, the context is quite striking. The prevalence of functional neurological symptom disorder, it's reported to be up to, 15.0% of neurology clinic referrals?
And 9.0% of neurology admissions. That's really a significant number of patients we're talking about.
It is, and as the paper points out, these patients often show up with acute sensoromotor symptoms. Sometimes they look exactly like emergencies, like a stroke.
Making that distinction quickly is vital for management, for resource use.
Precisely. And historically, maybe FNSD didn't always get the focus it deserved, sometimes treated almost like a diagnosis of exclusion.
Right, rule everything else out first.
But things are shifting. With these validated clinical techniques, these positive signs, it's becoming more of a positive diagnosis. This review helps clarify those validated techniques specifically for functional limb weakness, or FLW.
Which they define simply as weakness without that structural or electrophysiological cause.
Compared to ONW, objective neurological weakness, which does have that underlying cause. And they looked at 13 studies in total covering these 9 key techniques.
Okay, so let's get into the techniques themselves. The review groups them a bit by the principle they're based on. Some rely on complementary opposition.
Yes, that's a big one. Complementary opposition, basically, how a strong movement on one side or in one direction influences the force or movement contralaterally or in the opposite direction.
The body's sort of natural tendency for synergy or counterbalancing.
Exactly. And in functional weakness, this can show up in paradoxical ways. Let's start with probably the most famous one, Hoover's sign.
Everyone learns Hoover's sign, but the review really emphasizes using the specific validated technique.
That's key. So patient supine, knees extended, examiner's hands go under both heels or maybe the ankles. First step, baseline.
Get a feel for their usual downward push.
Right. Have them extend each leg fully down into the bed, note that force. Then test 1, patient lifts the unaffected leg, and you focus on the downward force from the affected leg. How does it compare to baseline?
Okay, and test 2.
Patient tries to lift the affected leg. Now you note the downward force of the unaffected leg compared to its baseline.
So the interpretation hinges on that paradoxical finding.
Correct. Test 1 is positive if the affected leg pushes down stronger than baseline when the unaffected leg lifts. Test 2 is positive if the unaffected leg's downward push is absent, or, minimal, definitely less than baseline when they try to lift the affected one.
And Hoover's sign is present if either test 1 or test 2 is positive. Suggests FLW.
Now, the validation data, it's interesting. The pooled estimate across studies gives really high numbers, sensitivity around 94.0%, specificity 99.0%.
Sounds great.
And it's significant, but the review points out there's only one prospective study, and it was tiny, just 8 participants. That one found much lower sensitivity, 63.0%, though specificity stayed high at 100.0%.
Okay, that definitely tempers enthusiasm. Pooled data from small studies needs careful handling.
Absolutely. The mechanism itself was validated quantitatively, showing real differences. But the sensitivity validation for that specific 2-step sign relies on really small numbers, initially just 4 patients, then prospectively 8. So the evidence quality, despite those high pooled numbers, is a bit limited.
So clinically, Hoover's is seen as a positive diagnostic feature, especially useful maybe for hip and hamstring weakness.
Yes, but like the review says, don't interpret it in isolation. That variable sensitivity, especially with limited data, means it needs context.
Hmm.
And it only works for lower extremity monoparesis. You need that strong contralateral limb.
Plus confounders like pain or hemi-neglect.
Right. And critically, there's no validation for doing it seated or for just relying on one of the two tests. If you want the validated version, it's supine, 2 tests.
Got it. Okay, another one based on complementary opposition is the abductor sign, validated back in 2004.
Right. Patient supine again, examiner at the foot of the bed, hands on the lateral calves, legs extended, about 6 to 12 inches apart at the ankles.
Baseline first.
Yep. Have them abduct both legs fully against your equal adductive force. Note the strength. Then test 1. Keep the affected leg midline. Unaffected leg is abducted. Patient focuses on abducting the unaffected leg. You note the abduction force in the affected midline leg compared to baseline.
And test 2 is the reverse setup.
Exactly. Unaffected leg midline, affected leg abducted. Patient tries to abduct the affected leg. You note the abduction force in the unaffected midline leg compared to baseline.
Interpretation sounds similar to Hoover's again. Baseline weakness might be present in either FLW or ONW.
Right. Test 1 is positive if that affected midline leg exerts more abduction force than baseline when the other side works hard. Test 2 positive if the unaffected midline leg exerts less force than baseline when they try to abduct the affected side.
And the validation data for this one?
Comes from just one study. 33 participants, 16 FLW, 17 ONW, all with unilateral or unequal weakness, and they reported, well, 100.0% sensitivity and 100.0% specificity.
Wow. Again, perfect scores raise an eyebrow.
They do, and the review flags the limitations. Unblinded examiners, which is a potential source of bias, and no data on inter-rater reliability. So promising, yes, but interpret those perfect numbers with a degree of caution.
And clinically, things like pain or trouble following commands could still confound it.
Definitely. Now, there's also an upper extremity sign using the same principle. The elbow flex X sign, validated in 2014.
How's that done? Patient standing or seated?
Either. Arms out front, elbows flexed about 30 degrees. Examiner holds both wrists.
Baseline is just standard manual muscle testing for elbow flexion extension.
Correct. Get a feel for their strength. Then, test 1. Patient flexes the unaffected arm against your resistance. You feel for any oppositional movement, so extension force in the contralateral affected arm compared to its baseline. Then they extend the unaffected arm. You feel for flexion force in the affected arm.
Okay, so looking for that involuntary counter movement. What about test 2?
Test 2 involves trying to move the affected arm against resistance while you feel the unaffected arm. But the validation study found test 2 wasn't sensitive or specific. So really, the elbow flex X sign is considered present if test 1 is positive.
Meaning you feel greater oppositional force in the affected arm when the unaffected arm is working.
Exactly. The validation study had 54 participants, 10 FLW, 21 ONW, 23 controls. It showed 100.0% sensitivity and 100.0% specificity using test 1 alone.
But again, examiners weren't blinded.
Right. So a positive test 1 seems like a strong indicator of likely FLW based on that study, but keep the unblinded aspect in mind.
Okay, let's switch principles. What about tests looking at inconsistency or that sort of mismatch between effort and actual force? Giveaway weakness is the classic one here.
It is, sometimes called collapsing weakness. The principle is that inconsistent strength exam those abrupt fluctuations in force rather than the sustained resistance you'd expect with organic weakness.
And the technique itself?
Well, the review notes that studies describing the exact validated technique are actually lacking. But the general idea involves isometric contraction against progressively increasing resistance. Say, patient supine, lifts the affected leg a foot or two off the bed, you push down with steadily increasing force.
Interpretation is crucial here.
Very. A positive sign is that sudden, complete giving way the limb just abruptly drops. It's different from a gradual failure. Sometimes it might look like ratcheting or just significant variation in strength.
And the validation numbers for giveaway.
Pooled data suggests high sensitivity, around 97.0%, but the specificity is much lower, about 63.0%.
That low specificity is a real issue. It means you have to be very cautious using it to rule in FLW.
Absolutely. And because the exact technique isn't really standardized in the validation studies, it's hard to know if your specific way of testing matches what generated those numbers.
Though the review mentions a dynamometer study had better results,
It did. Using a break index measure, got 100.0% sensitivity and 89.0% specificity. That does lend some objective support to the idea, but overall, there's still not much data on positive predictive values for the clinical sign.
And clinically, you need to be careful. Pain could cause giveaway, right? Or tremor, myoclonus.
Or even just limited attention or confusion. Lots of confounders. And obviously, you can't test it in someone with complete paralysis.
Okay. Another inconsistency sign, validated more recently, is paradoxical wrist flexion.
Right, 2021. This one uses biomechanics, the idea that muscles are strongest when maximally shortened. For wrist flexion, that should be when the wrist is already flexed.
Makes sense. So the technique.
Patient seated, elbows flexed at 90 degrees. Test 1. On the affected arm, palm up, supinated, make a fist, wrist fully flexed so the fist points up. Patient resists maximally as you try to pull their wrist down to neutral. Note that flexion strength.
Okay. Test 2.
Same arm, but palm down, pronated. Make a fist, wrist neutral, flat with the forearm. Patient resists maximally as you try to push their wrist upward into extension. Again, note the flexion strength.
And the paradoxical part is?
It's positive if they generate more wrist flexion force in test 2 with the pronated neutral wrist than in test 1 with the supinated already flexed wrist. That reversal is what suggests FLW.
Interesting. What did the validation study show?
It involved 24 patients with FLW, found sensitivity of 67.0%, but specificity of 100.0%.
So good for ruling in if positive, given that specificity.
Okay.
But only moderate sensitivity means a negative test doesn't rule FLW out.
Exactly. And clinically, it's really only for mild to moderate weakness. Severe weakness, they can't do it. Plus, wrist pain or previous surgery could mess up the results.
Right. Then there's motor inconsistency, which sounds, well, vaguely defined.
It is probably the least specifically described validated sign. The principle is simply that FLW is often movement-specific, doesn't follow neat nerve or muscle distributions.
But the validation study didn't spell out the exact exam maneuver.
No, it didn't. So the review proposes some techniques based on the principle. For example, do your baseline manual muscle testing, find severe weakness or paralysis while they're supine. Then, watch them carefully as they transition. Sit up, stand, maybe walk with supervision. Looking for inconsistency. Does that limb that couldn't lift against gravity supine suddenly seem to work when they're sitting up or trying to stand? Does the weak arm help push them up?
So interpretation is basically unable to do task A at baseline, but then shows ability during task B involving the same limb.
Pretty much, but the validation data is really limited based on only 7 FLW participants. It reported very low sensitivity, just 13.0%, although specificity was high at 98.0%.
With sensitivity that low, it's not reliable for ruling out FLW, and the lack of a clear technique makes it tricky.
Very. It's probably best looked for in severe weakness cases. Compensatory moves in milder weakness could easily be confusing.
Okay, moving on. What about tests using gravity and tone, the Spinal Injury Center test?
Validated in 2004. This one uses the natural tendency to maintain tone against gravity, but it's specifically for patients with severe lower limb weakness or complete paralysis.
So they have to be unable to lift the leg off the bed voluntarily at baseline for the test to even apply.
Correct. That's a critical prerequisite. Technique. Patient supine, legs extended. You take the affected leg, flex the knee, place the foot flat on the bed, so the knee points up, hold it there briefly, then remove your hand while directing their attention elsewhere, maybe to the unaffected leg.
And the positive sign
is if, after you let go, the patient keeps the affected leg in that position even for a moment without it immediately collapsing flat. Despite being unable to voluntarily lift it, that maintained position is disproportionate to their tested voluntary strength.
What's the validation data like?
Quite strong, actually. High sensitivity, 100.0%, and specificity, 98.0%. But it's based on one study with only 14 FLW participants.
So a positive sign seems quite indicative, and useful maybe if Hoover's or abductor signs aren't clear.
Exactly, because it doesn't rely on that complementary opposition principle, but again, only valid in severe weakness or paralysis. Someone with mild weakness might just hold the position passively.
Right. Okay, last category, signs involving associated movements, or synkinesis. The abduction finger sign.
Validated in 2008. Uses that idea of cross-body synkinesis, involuntary movements on one side when the other side exerts effort.
How's this done? Seated?
Yes, seated. Hands resting, palms down, maybe on their knees or a board, fingers hanging over the edge. baseline. Ask them to spread their fingers, abduct them fully on both hands. Note any movement in the supposedly paralyzed hand, especially the little finger.
Then the test itself.
You place your fingers to resist abduction on the outside of the second and fifth digits of the unaffected hand. The affected hand just rests, palm down. Patient focuses hard on abducting the fingers of the unaffected hand against your resistance for up to 2 minutes. Meanwhile, an observer watches the affected hand closely.
Looking for involuntary abduction.
Exactly, especially that little finger. Interpretation. It's positive if you see that synkinetic abduction in the affected hand during the resisted effort on the unaffected side. This movement is actually expected in both FLW and in healthy individuals.
So the key isn't its presence, but its absence.
Precisely, in the right context. Its absence in a severely weak or paralyzed limb might indicate ONW because these associated pathways can be disrupted by organic lesions.
What about validation?
There was a blinded validation study. Well, interpretation was blinded with 57 people, 10 FLW, 11 severe ONW, 36 healthy controls. They reported 100.0% sensitivity and 100.0% specificity.
How so?
The synkinetic movement was present in all the healthy controls and all the FLW patients, but it was absent in all the severe ONW patients. Surface EMG confirmed muscle activity in the FLW group, even without voluntary movement, but none in the ONW group during the test.
Crucial clinical point, though. This is only really interpretable in patients with complete paralysis of the hand muscles being observed.
Absolutely. Synkinetic movements can sometimes still occur even with incomplete organic weakness. You need that baseline of complete voluntary paralysis for the absence of synkinesis to strongly suggest ONW.
Okay. One more sign, sometimes linked to this organic versus functional question, drift without pronation. Based on Bavinsky.
Yes. Patient seated, arms held straight out forward, palms fully supinated, fingers together, nothing blocking the hands, eyes closed for 10 seconds.
And you watch for drift.
Right. Interpretation. It's considered positive for FLW if the arm drifts downwards without pronating. The classic organic upper motor neuron sign is drift with pronation.
Validation.
An unblinded study looked at 26 patients with upper extremity FLW and 28 with ONW. All the FLW patients showed drift without pronation. Only 2 ONW patients did.
That yield 100.0% sensitivity and 93.0% specificity.
Yeah.
But they excluded patients with complete paralysis.
Correct, because you need to be able to hold the arm up initially to see drift. So clinically, it's best for mild to moderate upper limb weakness, and difficulty holding full supination at baseline could affect the accuracy.
Okay, so that covers the 9 specific validated techniques from the review. But just knowing the tests isn't enough, right? What's the bigger picture takeaway?
Absolutely. The review really stresses that interpreting any of these findings has to happen within the context of your full neurological exam and the patient's history. No single positive sign is diagnostic on its own.
Look at the whole clinical picture.
Exactly. And they suggest that your assessment might be more reliable if you use tests that tap into multiple underlying principles. Combine a complementary opposition sign with, say, an inconsistency sign or a synkinesis sign.
Maybe even verify a finding using 2 different maneuvers based on the same principle. Like Hoover's and the abductor sign both look at complementary opposition in the legs.
That's a good strategy. Which maneuvers to pick? The review says it's situation dependent. But testing for multiple signs using different principles probably increases your diagnostic yield and your positive predictive value.
They also mention other validated tests, briefly, like for face or neck weakness.
Yes, the sternocleidomastoid test or the platysma sign. They assess for functional weakness elsewhere but can co-occur with limb weakness. They generally have high specificity, maybe 90.0 to 100.0%, but more moderate sensitivity, around 63.0%.
What about modifying techniques? Can we adapt the principle, say, of paradoxical wrist flexion to the ankle?
The authors touch on this. While the principles themselves are physiologically interesting, applying them in ways that haven't been specifically validated, like testing paradoxical strength at the ankle, means you have to interpret those findings with extreme caution. Stick to the exact validated techniques for the highest confidence.
So the keys are, use the exact validated techniques, use multiple techniques, and tap into different underlying principles. That should improve diagnostic accuracy.
That's the idea. Patients with FLW often do show multiple signs across different modalities: motor, gait, sensory. A comprehensive approach helps improve your diagnostic certainty and, importantly, minimize misdiagnosis. Getting the diagnosis right is crucial for appropriate patient care and management.
And a really critical point they make, about 19.0%, nearly 1 in 5, patients with documented objective neurological weakness also have at least one positive sign suggesting FLW.
Yes, that overlap is significant. Comorbid anxiety and sensory deficits were flagged as risk factors for this co-occurrence. It really underscores the need for a thorough exam to look for objective findings, even if you see functional signs, because many patients might actually have both.
Definitely. And finally, we always need to keep the limitations of the validation studies in mind.
For sure. Those 100.0% sensitivity or specificity figures, interpret them carefully, especially if they come from studies with very small numbers of participants. And the issue of unblinded examiners is a potential bias in several studies. Future research really needs blinded interpretation.
Okay, so wrapping this up, what does this deep dive into the Dolbo review mean for you in your day-to-day practice?
Well, I think it really highlights the value of a skilled physical exam, specifically using these validated techniques, when you're faced with weakness that might be functional, or organic, or potentially both.
It's not just about knowing the steps for Hoovers or the elbow flex X sign, is it? It's about understanding the principles behind them.
And recognizing that a comprehensive assessment, looking for multiple signs across different categories, complementary opposition, inconsistency, synkinesis, gravity, is much more robust than just relying on one single finding.
Especially given that overlap between functional and organic symptoms and keeping the limitations of the validation studies in mind. So the final thought for you, the listener, is perhaps, how might consciously incorporating a more systematic approach using these specific validated maneuvers change your confidence and maybe even your efficiency when you evaluate that next patient presenting with motor weakness?